Welcome, everyone. Thank you for joining this SCT seminar. I'm Keith Channon from Oxford in the UK, and I'm very pleased to be moderating today's webinar. Caristo Diagnostics is the sponsor of today's seminar. We're very grateful to Caristo. Caristo's CariHeart product quantifies coronary artery inflammation from routine coronary CT scans, and this is very relevant to the topic of today's webinar, which focuses on the results of a recent and very high-profile Lancet publication reporting the first results from the world's largest cardiac CT registry, the ORFAN study, led by Dr. Harris Antoniades, who I'm very pleased to introduce as our keynote speaker today. Following Dr. Antoniades' presentation, we'll have a 30-minute panel discussion with our expert panelists, who I will introduce to you later. Please submit your questions and comments online during the presentation and the panel discussion so that we can ask the panel to discuss as many of the points that you raise. But for now, I'm going to hand over to Dr. Antoniades for his presentation.
Hello, I'm Harris Antoniades from the University of Oxford, and it's my great pleasure to be with you tonight to present you the results of the ORFAN study. The first results of this large outcome study have been published in the Lancet a couple of weeks ago, and the paper is entitled Inflammatory Risk and Cardiovascular Events in Patients Without Obstructive Coronary Artery Disease, the ORFAN multicentre longitudinal cohort study. These are my disclosures, the most significant one of which is the fact that I'm founder, shareholder, and chief scientific officer of Caristo Diagnostics, the company that is sponsoring this symposium. Now, I would like to start by outlining the problem. Cardiovascular disease is a massive health economic problem in the Western societies. In the US alone, and this is from a very recent paper published in Circulation, there is a healthcare cost of $600 billion a year, and this is expected to come up to $1.8 trillion by 2050. These are massive costs for the healthcare systems and for the society. If you analyze now what constitutes this cost, you will see that most of it comes from coronary heart disease, while there's an additional cost from stroke, atrial fibrillation, and heart failure, as outlined here, and some additional costs from the other cardiovascular diseases. We now know that going beyond the classic risk factors, inflammation is a critical factor that not only triggers the development of atherosclerotic plaque, but it also leads to atherosclerotic plaque rupture. We know now that nearly all the risk factors exert their effect on the vascular wall, at least partly, by increasing vascular inflammation. And we know that if we treat patients with anti-inflammatory agents like canakinumab or colchicine, we reduce the risk for cardiovascular events accordingly. This is why the most recent ESC guidelines have introduced in 2021 colchicine as a way to reduce cardiovascular risk in high-risk individuals, and the FDA has given clearance of colchicine with this cardiovascular risk reduction label a few months ago. Now, in my lab in Oxford over the last 15 years, we were focused on understanding how the vascular wall communicates with this environment, and particularly with perivascular space. And we have seen that when you have an inflamed artery, that inflamed artery secretes inflammatory molecules in the perivascular space, and the perivascular adipose tissue surrounding the vessels senses these signals coming from the vascular wall, and it changes its structure and composition. Now, these changes are normally not visible in routine coronary CT angiography because it's this black space around the coronary arteries. We developed a few years ago a method that is called fat attenuation indexing that brings this information to the surface. And when you see this yellow color, it means that the artery is not inflamed. If you see the red, it means that there is inflammation coming from the artery. If you see blue, then it means that there is severe inflammation coming from the artery. And this is an example of a case with a STEMI, and you will see that near the obstructive disease, the rupture plaque, you see how inflammation is lighting up as red or even blue color in the perivascular fat. So with this method, you can identify not only the inflamed arteries, but also the inflamed lesions within the arteries. Now, when we describe the fat attenuation index, this metric that measures inflammation from routine coronary CT angiography on the coronary arteries, we then tested in the CCTA study whether this increased inflammation is related with increased risk for fatal and non-fatal cardiovascular events. And indeed, in the CCTA study, we found that the fat attenuation index leads to 5.6 to 9 times higher risk for a fatal cardiac event and around 5 times higher risk for a non-fatal cardiac event over the next 8 to 10 years after the patients have the coronary CT angiogram. Of course, when we first described the fat attenuation index, it became clear that in order to turn this metric into a clinical measure of coronary inflammatory risk or coronary inflammation, we had to introduce a number of corrections for technical factors, biological, and anatomical factors that will make this metric more reproducible. And indeed, more recently, we developed the fat attenuation index score, which is the standardized AI-enhanced way to estimate coronary inflammation from routine coronary CT angiography. And this is a metric that has received this label in Europe and the UK and Australia as a metric of coronary inflammation for clinical use. This metric is interpreted in age and sex-specific nomograms, as you can see in this figure. The need for standardization in quantitative perivascular adipose tissue imaging was also highlighted in a recent clinical consensus statement from the European Society of Cardiology, the working group of coronary pathophysiology and microcirculation, that outlined the need of these kind of robust methods of measuring inflammation in the perivascular space in order to generate clinically applicable tools. Now, we have discussed now about these new metrics of coronary inflammation that have prognostic value, but we know that quantity plaque metrics, they also have, all these metrics, they have a prognostic value, including also the risk factors and also our clinical judgment. The big question is how to integrate all these different pieces of information into a risk prediction score or a risk prediction tool that will allow us to translate this into clinical practice. This is where artificial intelligence enhanced tools can come into play and integrate these results, allowing us to optimize the ability to predict cardiovascular risk and modify treatments for our patients. This is exactly what the British Heart Foundation, through a translational award in the UK, has funded, and that led to the development of an artificial intelligence risk model that essentially gets routine coronary CT angiograms, extracts information from the images about inflammation and about plaque, then it integrates this information into a prognostic model together with the risk factors of the patient, and it generates the absolute and the relative risk of the patient for a fatal cardiac event over the next decade. And this then triggers management based on the clinical guidelines, because then you have converted these individual metrics into actionable risk classification. Indeed, this model was originally trained in a US population in the CCTA study, and it was validated externally in a German population. And you can see how the model performs significantly better compared to the risk factors-based prognostic models in the CCTA study. Of course, in order to enable global generalizability of these AI-enhanced prognostic models, we need external validation in large cohorts across different continents and different ethnic groups. This is exactly what we have done in the ORFAN study, which is the focus of this presentation today. The ORFAN study is the world's largest prospective outcomes cohort of coronary CT angiography in patients undergoing coronary CCTA as part of clinical care. It aims for 250,000 patients. At the moment, we have enrolled 135,000 patients with 3 to 15 years outcomes linked with these scans. And the paper that I will describe to you, present you now, is focusing on the first 40,000 of these patients approximately. This cohort aims for 200,000 patients from the UK, but it also includes patients from the US, from Latin America, from Australia, Asia, etc., and of course Europe. Now, there are three different metrics that I will focus a discussion on in this paper. The first is the fat attenuation index score, is what I have described to you earlier as the metric of coronary inflammation of each one of the three coronary arteries interpreted in age and sex-specific nomograms. The second metric is the AI risk. This is an 8 years risk prediction model that integrates the FI score, the inflammation, together with the risk factors of the patient and the extent of obstructive coronary artery disease. The third parameter that I will present to you and we evaluated in this paper is the A-risk classification model. We know that when you have a risk prediction model that gives you absolute risk, you need to convert this into actionable treatment cutoffs. And this is exactly what we have described a few years ago when we created these three different classifications. We have the patients with low, medium risk. These are the patients who have low absolute risk and low inflammation of the coronary arteries. Then we have the patients of high risk who have intermediate, I would say, inflammation in their coronary arteries and intermediate risk. And we have the very high risk category, which are the patients who have either very high absolute ATR risk or they have very highly inflamed coronary arteries, at least one very highly inflamed coronary artery. The objective of this study is exactly to externally validate the prognostic value of the FI score in each coronary artery, the AI risk prognostic model, which is the absolute ATR risk for a cardiac death, and the AI risk classification, which is the actionable risk categories I have described you earlier. Now, in this study, we enrolled the first cohort, which consisted of 40,000 patients undergoing coronary CT angiography as part of clinical care. They were followed up for a median of 2.7 years, and the outcomes data were collected through national registries in the UK. This is a UK-only population of the ORFAN study. In the second cohort, which is a nested study within the 40,000 patients, we enrolled 3,393 patients, and these were the patients with the longest follow-up, a median follow-up of 7.7 years after they had the coronary CT angiogram. Data collection was identical as with the data collection in the larger cohort. Now, looking into the overall population, the 40,000 patients, you will see that, as expected, 18% of this population was diagnosed based on the CT angiogram with obstructive coronary artery disease, while 82% did not have obstructive CAD. Obstructive CAD is defined as stenosis more than 70% on the coronary CT angiogram. If you look now into the prognostic value of the presence of obstructive coronary artery disease, you will see that patients with obstructive disease, they had a hazard ratio of 1.4 for cardiac mortality and 1.5 for MACE, defining MACE as a combination of cardiac death, non-fatal MI, and new heart failure. I will present to you the individual hazard ratios for each one of the individual endpoints, but in the rest of the paper, I will focus specifically on the MACE as a combined endpoint. The most important finding from this first cohort, or nested study within the ORFAN cohort, is the fact that in absolute terms, there were 2 times more events coming from those 82% of the population without obstructive CAD. This means that if we focus our attention on this 18% of the population who has obstructive CAD, we can potentially modify the risk of the 1/3 that leads to 1/3 of the events observed in this population. And we are missing the population that will give the 2/3 of the events from the patients undergoing the clinically applicable coronary artery CT angiography. Looking now into the individual endpoints, you will see that the hazard ratio for cardiac mortality and MACE was very similar, around 1.4. If you look into the myocardial infarction, it's a bit higher, 1.7. New heart failure was a bit lower, 1.2. But these are the individual hazard ratios that we need to keep in mind to understand the rest of the paper. Now, focusing on the FI score, I will present you here the FI score readings from the LAD, but the results are very similar for the circumflex and the RCA. You will see that patients with high inflammation, so patients that belong to the highest quartile of the distribution of FI score in the LAD, they had 20 times higher risk for a fatal cardiac event and 6.7 times higher risk for MACE over the next decade. If we focus on those without obstructive CAD, the ones that do not go to the cath lab for further investigation, you will see that again, patients on the highest quartile, they have 10 times higher risk for a fatal cardiac event and 4.7 times higher risk for MACE. Focusing now specifically in that subgroup of patients with minimal or no atheroma, these are the patients with CATRAS 0 or 1. These are the typical patients that we reassure and we discharge from specialist care. These patients consist nearly half of the population, a bit less than half of the population of the study, and they give significant number of events. If you focus specifically on this cohort, you will see that having FI score in the LAD in the top quartile leads to 9 times higher risk for cardiac mortality and 5.5 times higher risk for MACE. If you look into the circumflex and the RCA, the values are very, very similar. Where we have a similar increase of the risk for fatal and non-fatal cardiac events among these individuals, independently from where we calculate, on which artery we calculate the FI score. Now, in the paper, that when you read the full paper, you will see two terms, the term total inflammatory risk and residual inflammatory risk. What does the total inflammatory risk mean? That inflammatory risk is the one that is captured by the FI score in each individual coronary artery without any correction for risk factors or the extent of coronary artery disease. The residual inflammatory risk is what is the hazard ratio, is the risk that is left after we correct this total inflammatory risk for the risk factors, the classic risk factors, the medication that the patients are receiving, and also the CATRAS-2 stenosis classification status. So when you correct for all the risk factors and CATRAS, you will see that the hazard ratio barely changes, which means that the contribution of the risk factors into this risk is significant, but it's small. And it's a very similar phenomenon when we focus on MACE instead of cardiac mortality. Total inflammatory risk, very well captured by using the FI score in any of the 3 coronary arteries, barely changes when you correct for risk factors and the CATRAS stenosis classification system. Another interesting analysis that we performed in this study was to explore the add-on effect of the number of inflamed coronary arteries on the risk prediction. You will see that those individuals who have all 3 coronary arteries with FI score below the 25th centile, these are the ones who have very low inflammation of the coronary arteries, they essentially develop a very, very small number of events. This is a power of 0 for the FI score. Patients who have at least one inflamed coronary artery above the 75th centile, they have a hazard ratio for developing a fatal cardiac event of 13. And then when you have 2 coronary arteries, that goes to inflamed, that goes to 20. And when you have 3 inflamed coronary arteries, the hazard ratio goes 29.8. A very similar effect is observed when you focus on MACE, and it's there in those patients with obstructive disease and in those patients without obstructive CAD. So this is a very, very striking phenomenon that tells us that the number of inflamed vessels increases dramatically the risk for fatal and non-fatal cardiac event. Now, the next objective was to evaluate the performance of the AI risk prognostic model in a UK population. Remember that this model was trained in US population and was not tested in the UK. Applying this in the UK, we observed that we can achieve with the AI risk prognostic model for a fatal cardiac event over the next 8 years, we achieved an area under the curve of 0.844 in the whole population. And if you look into the contribution of the individual arteries, the phi score of the individual arteries into the risk, you will see that even ignoring the extent of coronary artery atherosclerosis, if you ignore the risk factors, then you get an area under the curve which is very similar to what you get with the combined model. This means that most of the risk captured by the AI risk model is described by the inflammatory risk that comes from the inflammation in 1, 2, or 3 of these coronary arteries. If you look into the calibration curves that compare the AI risk prediction versus a true observed risk, you will see that the predicted curve nearly overlaps entirely with the ideal curve, which is the 45 degrees straight line. And this is maintained with this high performance in those without obstructive CAD, which is the main focus of this paper and is the main target population that definitely benefit from knowing the inflammatory risk in their coronary arteries because they are not receiving the appropriate treatment today. Looking into the AI risk model as a continuous variable, then you will see that whether you further correct for the mitigation of the patients, or if you further correct for cataracts, this doesn't really change anything in terms of the hazard ratio, the ability to predict events by using this model as a continuous variable. Now, the third parameter that we evaluated in this study was the AI risk classification. So these are the actionable categories that trigger changes in clinical management, taking into account the absolute risk prediction and the inflammation in the coronary arteries. Based on the AI risk model, we could predict that these will be the events that will be observed if the model was performing 100% in predicting risk. The green line refers to the patients with low medium risk. The orange line refers to the patients who are high risk, and the red line is a very high risk population. When we then recorded the true events observed in this study, you will see that there was a remarkable overlap between the predicted events and the true observed events over a decade after the index coronary CT angiogram. There was a very striking phenomenon that allows us to be very optimistic that this model actually captures nearly all the events that truly happen in the population. If you focus now on those patients without obstructive CAD, these are the predicted curves and these are the observed Kaplan-Meier curves. Very good overlap between the two. However, when you focus on those patients with obstructive CAD, you will see that especially during the first 3 years, the medium to low and the high risk groups, they seem to be significantly lower in terms of actual events observed compared to the predicted events, while after year 3, the curves come back exactly where they were originally predicted to be. Why is this happening? So looking into the data, you will very easily realize that these are the patients with a diagnosis of obstructive CAD as a result of the coronary CT angiogram. All these patients went to the cath lab immediately after they had the angiogram, the non-invasive angiogram. They had an invasive angiogram, and then they had treatments. They had PCI, they had bypass surgery. It seems that this has reduced the true events, and then these true events came back to where they were meant to be after 3 or 4 years. When these individuals stopped their dual antiplatelet therapy, they started developing in-center stenosis and other complications that led eventually to the events to catch up with the original prediction. So this is a very interesting observation that proves that what we do in the cath lab, what we do as cardiologists, does work, at least by pushing these events 3 to 4 years later. The same phenomenon was observed for MACE. Again, you had a very good prediction of risk in those patients without obstructive disease, while in those with obstructive CAD, you have overestimation of risk of during the first 3 years, and the risk caught up after year 3. Focusing now on the patients with obstructive CAD, we added on top of this model the quantitative assessment of plaque, calcified plaque and non-calcified plaque, aiming or hoping to see that this will improve the risk prediction in these first few years. However, this was not the case. Adding quantitative plaque assessment on top of the AI risk model did not really move the needle. It did not change our ability to predict events during the first 3 years, and that's mainly because the events were not driven were driven by interventions, by a responsiveness to medication that is given after the patients had the coronary CT angiogram. Now, the phi score and the AI risk, they predict events also independently from calcium score. In a subpopulation of about 1,300 patients from the study, we corrected the hazard ratios for predicting events for phi score in any of the 3 coronary arteries, as well as the AI risk for the calcium score. And you see that the needle did not really move. Correcting for calcium score does not really change the ability of the phi score or the AI risk prognostic model to predict risk. Now, if you want to change the future, you must change what you are doing in the present. This is exactly why we need to focus now next in how can we modify the risk that we can predict, and how can we prevent the events that we predict that they are going to happen. Intense statin treatment seems to be the number one option that we have in our hands today. There are a number of studies showing that statin treatment reduces risk, and it also reduces the fat attenuation index. In this very recent study that was published a few weeks ago, it became clear that the predicted AI risk is reduced by around 50% after intensive statin treatment, even within a year from initiation of statin therapy. This is maintained over 3 years. And this was the duration of this study. On top of statin treatment now, what can we do? We can consider more aggressive anti-inflammatory treatments like, for example, antioxidase LDL. This is a study that was published just a few weeks ago again, demonstrating that on top of maximum statin treatment in a population with high coronary inflammation, which is the population with psoriasis, when you treat these individuals with antioxidase LDL monoclonal antibody, you have again around 40% further risk reduction beyond what you have achieved with the aggressive statin treatment. This means that as a second-line medication, we can consider anti-inflammatory treatments, and definitely antioxidase LDL could become one of the options in the coming years for further treatment of cardiovascular risk in patients with high coronary inflammation. Now, this AI risk classification that I described earlier can potentially transform clinical care. NHS England has already commissioned the use of this technology in the NHS in the first 5 hospitals. And in the first 744 patients who had this pilot deployment of the technology, the NHS England has observed change in management in 45% of these individuals. 24% started new statin treatment, despite the fact that they met the LDL targets and they were not meant to start statin treatment based on the current clinical guidelines. 13% intensified statin treatment when the current guidelines were not suggesting intensification of statin treatment, and 8% was already on maximum dose of statin and they needed additional treatments, And these are the patients that were tested on colchicine, additional aspirin treatment, and so on. So if we can see the future, we can certainly change it. I'm sure that if Doc from the Back to the Future movie in the 80s had this technology in his hands, he wouldn't really need to invent the time machine. I would like to thank the co-authors, the investigators that participated, the orphan investigators that participated in this study, the wider orphan consortium, and most importantly, I would like to thank the funding bodies who support the orphan study, and particularly Cardiovascular Diagnostics, not only for sponsoring this symposium, but also for supporting in kind the deployment of the study infrastructure in the various sites in the UK and in the rest of the world, in the US, etc. Thank you.
Great. Thank you so much, Dr. Antoniades, for a superb presentation. You covered an enormous amount of information. It's a really impressive piece of work that you published in the Lancet recently. Congratulations. You've given us a lot to talk about, a lot to think about. So I'm going to, first of all, remind our audience members, please continue to submit your questions in the online Q&A. And then I'd just now like to introduce our panelists who are shown on this slide. You've met Dr. Antoniades through his presentation. I'm pleased to introduce also Professor Ed Nicol from the Brompton Hospital in London, Professor Ron Blankstein from Harvard Medical School, Professor Stefan Neubauer from the University of Oxford. Dr. Desai from the Cleveland Clinic hasn't been able to join us. We know that he's traveling, but he might be able to participate partly. So if he does, we will welcome him. And the panelists wish to share their disclosures as shown on the slide here. So we've got a number of questions that have come in, and I'm going to try and put them to the panelists in a way that keeps us in some sort of logical progression. And I wanted to start, first of all, perhaps by asking Dr. Blankstein and Dr. Nicol on their perspective of how this new technology fits with the context of coronary CT. We've seen a really amazing transition from non-invasive imaging that's principally designed to detect ischemia to non-invasive imaging that is designed to detect the consequences of the disease, meaning plaque and obstruction and stenosis and its consequences. How do you see this new technology as fitting? Perhaps, Dr. Blankstein, you can give us a short perspective from a US point of view, and then Dr. Nicol can give some further comments.
Sure. Well, I want to first start by congratulating Harris for leading this study. I mean, such an important study for the field of cardiac CT, and immense amount of work that I know that has gone into it. Well, while that study has been going on, there's a few things that have been happening in the field of cardiac CT. First of all, we've had a lot of other studies showing the value of cardiac CT and plaque, and ultimately they led to wider adoption of CT throughout the globe. So now both in the US and of course European guidelines, cardiac CT, coronary CTA specifically has a class 1 indication, was the strongest level of evidence of any modality right now for the evaluation of chest pain. And the reason for this is not just that it can tell us who's at high risk, and it also tells us who's at low risk. And the other reason is the fact that this is the only test right now that can identify plaque when it's not flow limiting. And then the other, very important attribute is data showing that based on the results of CT, we can actually see beneficial changes in outcomes. In fact, the only test that has been shown to improve outcomes. So with that particular context, there's now a very big focus on non-obstructive plaque. After all, that is the most frequent finding after patients have coronary CTA. So here it just showed very important data from ORFAN that the majority of patients, and this is of course not just in ORFAN, also shown in other studies, the majority of patients who undergo a coronary CTA are not going to have obstructive disease. That seems to be kind of the tip of the iceberg. but they're going to have non-obstructive disease, and it gives us a very big opportunity to identify those patients, to initiate preventive therapies. But it now also means that we have a challenge to decide what are those preventive therapies. We have a lot of good therapies in the field of prevention, and this is such a large cohort of patients. So how do we further risk assess? How do we further refine the risk and tailor the right treatment for the right patients? And this is, exactly where the field of cardiac CT is right now.
Great. Thank you, Dr. Blankstein. Dr. Nicol, I mean, you've had a long experience of coronary CT and also other imaging modalities. And as Dr. Blankstein has said, the majority of patients who undergo a coronary CT for clinical reasons, for good clinical reasons, they don't have obstructive disease. So I think that the information that Dr. Antoniades has shared with us and this new PHI technology to detect coronary inflammation, it does make cardiac CT more relevant to more people. Is that what you're seeing in your practice?
Yeah, absolutely. I mean, just to build on what Ron's just said, I mean, we know, both from Dave Newby-Scott heart data originally in a sort of randomized control way, but also in the very large, NHS cohort that Jonathan Webb published last year in JACC, that actually doing a CT coronary angiogram, and then acting on that result, leads to an improvement of both cardiovascular mortality and morbidity. But as just been pointed out, actually, historically what we've done in people, certainly with normal coronaries, is we've reassured them. And I think what is really interesting, I think, about the data that, ORFAN has shown us is that there is a cohort of people, particularly, I would say, people who we would have previously reassured, who actually maybe we should be a little bit more circumspect about, in the sense that we know that, about 30% of patients have a CT coronary angiogram participant actually have a completely normal CT coronary angiogram, or at least very minimal disease. And, it can often be quite difficult to, actually, really work out whether you've got a bit of luminal irregularity or not. Now, that I think will change with photon counting scanning, but, let's work on what we've got predominantly at the moment. But so I think this is where the real advantages. There is no doubt that plaque is fundamentally important, and the more of it you've got, the more important it is. And actually, the whole sphere of cardiology, the paradigm of cardiology has changed in the last, 5 to 10 years. And I think a lot of that has been driven by a non-invasive modality to look not just at the lumen, but also at the wall as well. But I think the really important thing here is actually what Harris's data shows is the fact that, the benefit of the inflammation and the changes in the PHI signal, actually is independent of and additive to the level of coronary artery disease. And I think, and we can't see it is the other thing I would say. We can see plaque, and we can, as human beings, we're pretty good at quantifying it. We do like to put numbers on things, but actually on the whole, we're pretty good at seeing it and to a degree knowing what to do about it. But here is something that we can't see with our own naked eye. And I think that's what I think, should make us all sort of stop and pause. And, as Ron's alluded to, we've got some quite tricky things to now work out as to how best to treat these patients. But actually, we probably need to give it a decent amount of thought. And there are brighter, better people than me who know that field better. So, that's what I would say.
Thank you, Dr. Nicol. I mean, just to summarize, you've highlighted a number of really important points here, that this is a new technology. Quantifying coronary inflammation is obviously complementary to the detection and characterization of plaque. But given that the majority of patients don't have obstructive plaque and a substantial number don't have any or minimal plaque, coronary inflammation is a major factor that has been invisible, but now for the first time we can quantify. And so I think in that regard, it's a real game changer. We've got a whole bunch of questions coming in about what to do with this information that is generated by PHI score calculation, and we'll come back to that later. We've also got a set of questions on technical aspects, and I might ask Dr. Neubauer just to answer some of these, and I'll put them together if I may, because we've got quite a few. I mean, the first is some of the technical aspects of what type of CT coronary angiogram is needed for a PHI score calculation to be undertaken. And then the second is trying to understand the difference that Dr. Antoniades did comment on, which is the early research showing that the use of raw fat attenuation Hounsfield units gives some information, but of course the clinical product, the PHI score, is now a much more nuanced, sophisticated clinical readout because it incorporates much more information. Dr. Neubauer, do you want to speak about a few of those points?
Yes, maybe take them one by one. So the first thing to say is that what Caristo has worked very hard on is to make this a universally applicable technique. So it is pretty much usable for any vendor, any cardiac CT scanner. There are just very, very few exceptions, like very low kV, for example, where we're still getting on top of that. But I would say 95% of the scenarios you would encounter, we can do this analysis. So that's the first thing to say. And maybe just to again briefly explain how phi score and the simple fat attenuation and AI risk work. So imaging the fat tissue around the coronary arteries on CCTA yields powerful new information on the presence and extent of inflammation, as you've heard. And this is done by measuring the Hounsfield changes in the pericoronary fat tissue, which change in the presence of inflammation due to increased water content. Now, the phi score extracts this information that is invisible to the human eye, and rather than just measuring the Hounsfield units for a parameter which in other literature is often called PCAT or PVAT, the phi score normalizes this fat signal for a whole range of factors: anatomical, biological, technical, and patient-specific factors. And this then makes it an accurate, reproducible, and robust measure of inflammation. And this phi score is then measured in all three coronary arteries and not just in the proximal coronary, in the right coronary artery, sorry. And then this AI risk, it's called in the Lancet paper AI risk, it's called Cari-Heart risk by Caristo. This takes the phi score for an individual patient and combines it with the traditional clinical risk factors, demographics, full CCTA plaque assessment, to then derive an absolute % risk of cardiovascular death over the next 8 years.
Great, that's very helpful. Thank you for clarifying that. One of the subsidiary questions, Dr. Neubauer, while you're telling us about that, is when this technology is likely to be available more widely for clinical use. I understand Dr. Antoniades told us that it's already approved in Europe and Australia. Do we know from Caristo when that's likely to be made more available for patients in the US, for example?
So yeah, so as you said, this Cari-Heart device is already CE marked, can be used in the UK, Europe, Australia. Cari-Heart is currently going through the FDA process for approval in the US. And we expect this to be, let's say, a few quarters away. But it is, of course, even in the US already available for research studies. So if you contact Caristo, I'm very happy to have a conversation about your research ideas.
Great, thank you for that. So there's lots of comments and questions which I'd like to turn to now about how the phi score information impacts on patient management. In other words, how should we use that information for potential patient benefit? I might go back to Dr. Antoniades to begin with, and then to Dr. Blankstein and Nickel. Dr. Antoniades, you did make in fact, you gave us 2 examples in your presentation about how medical therapies alter phi score, anti-inflammatory therapies alter phi score. I mean, how can you see the use of phi score fitting with routine patient pathways and ultimately treatment guidelines?
Yeah, that's a very good question, Keith. At the moment, we act upon risk. So we calculate the risk of the patient using pool cohort equations, or using the Q-risk-3 in the UK, or the ESC score in Europe. And then based on what risk level we have, we either start statin treatment, intensify statin treatment, or we consider additional treatments based on the clinical guidelines that include colchicine, with an indication that is 2B in the European guidelines, which means that we're not entirely sure who needs to be treated. So these are the patients that are identified by these new technologies as the patients that probably should be considered for this additional guideline mandated treatments. Now, beyond statins and beyond colchicine, we can introduce any other risk modification treatment that is included in the guidelines that we have in our hands, because we are treating risk. We treat inflammation because this is behind the risk, but ultimately the guidelines tell us how to treat the risk, and this is what we should treat at the moment. In the future, new treatments, I'm sure, will come. There are a number of clinical trials that are testing anti-inflammatory agents. We have the ZEUS, we have other studies that look into anti-IL-6 treatments, etc. When these treatments come out, and hopefully they are proven to modify outcomes, then we'll have the test that will help us to identify these patients in a more specific way than the circulating biomarkers can.
Yeah, great. Thank you. So Dr. Blankstein, colchicine is, of course, now an FDA-approved treatment for high-risk patients with coronary artery disease in the US. Is that a drug that is being used for high-risk patients, and how would you see Phi-score as a potential selection or as a treatment response measure to drugs like colchicine?
Yeah, no, it's a good question. But first, to kind of build on the concept of kind of how we treat patients, I mean, one of the things that I think is very impressive from the results that Harris presented is just how high risk is that high risk group. I mean, they have an incredibly high risk level. If I see in my preventive cardiology clinic someone with such a high risk, it's usually not just one therapy. Coronary disease is a very complex disease, and I'm going to try to target multiple therapies for that patient, getting their LDL as low as possible, obviously lifestyle, getting more aggressive blood pressure, lowering inflammation. Also, I'm about to talk about that too. But I would just emphasize that when we find these patients that have very high risk, we have to incorporate a multi-pronged approach, focusing on multiple interventions. And the good news is we have a lot of good interventions now. I didn't mention, for example, GLP-1 receptor agonist for patients with obesity or diabetes. So I'm going to start thinking a whole lot more beyond just colchicine and statins. Now, your question now is about colchicine, certainly approved in the U.S. Based on the LODOCO-2 trial and other studies. In that particular study, they took individuals who have known coronary disease or had a high calcium score and showed a significant benefit. I have to say that despite those results, the uptake of colchicine in the U.S. has been pretty small overall. I certainly use it in my practice when I have high-risk patients and I want to do everything for them. And I think maybe it's because I'm practicing at the birthplace of CRP and inflammation at Brigham and Women's Hospital. But across the U.S., I don't think the adoption of it has been that high. And there's multiple reasons for that. But I do think that the fact that we can now identify patients who have inflammation could be very useful in selecting those patients who may benefit from colchicine or perhaps other anti-inflammatory therapies in the future. And there's several reasons here why this is helpful. First of all, we sometimes think maybe CRP is helpful, even though that was not used in the LODOCO trial. They just treated everyone. But with CRP, we're detecting systemic inflammation. And one of the points that I think might be very important in imaging is it's more specific to inflammation around the coronaries. So I think that would be one real advantage of imaging over some of the biomarkers that currently we rely on.
Great. Yeah, no, thanks for emphasizing that, the importance of coronary artery specific inflammation being detected and quantified by Phi-score. And as Dr. Antoniades showed in his presentation, it's not just any one coronary artery or one segment, it's any or indeed all coronary arteries. And there's a per coronary artery gradation of risk with Phi-score.
And the reality is today, just to emphasize, colchicine is the only approved therapy for lowering inflammation. So if we have a patient with elevated inflammation and we want to treat that, at least in the US, that's the only option for today. So I certainly see that potentially being used more if we can identify inflammation in a more reliable way.
Right. And I guess there's an expectation that a biological process like inflammation is more likely to change more quickly in response to a targeted therapy compared with plaque, which we know from IVA studies going back over many years changes very slowly, even though risk reduces very quickly. I mean, on this topic, Dr. Nicol, of the importance of medical therapy, I mean, I'm an interventional cardiologist, so I've taken a long time to come to terms with this, but medical therapy is extraordinarily powerful for treating risk as opposed to the symptoms of ischemia. And the ischemia trial told us this. So to some extent, Phi-score is kind of helping us to explain why medical therapy is so powerful if we can target it to the right people. Do you think that's a fair comment? And what's your reaction to that?
Yeah, I think broadly, I think that's true. I mean, without getting into the nuance and the debate around the methodology of the ischemia trial, which is clearly an ongoing and hot topic and will be for a while to come, I think. You know, there's no doubt that one, you have to think very carefully before you actually intervene, you know, either interventionally or surgically on a coronary artery, you know, and unsurprisingly, it's not without, you know, risk. And in some cases, you know, that risk is fatal. I think just to build on, you know, Ron's comment around colchicine, though, I think, you know, we need to tread a little bit with caution here. My understanding of the data is, whilst cardiovascular risk is reduced in people, actually, you know, there is a signal that, you know, non-cardiac, you know, outcomes may actually be worse. And it's just, and I think this is where thigh or, you know, or coronary inflammation in terms of, you know, a more targeted approach may allow us to address people who really genuinely will benefit, you know, so actually that, if you like, the sort of, you know, the balance of risk and benefit actually is we can be more nuanced about who we treat with a drug such as colchicine. So, and I think, you know, more broadly than that, I think, you know, ischemia obviously was people who had a perfusion abnormality. That was how you got into the ischemia trial. So, of course, we're dealing with people predominantly at the most severe end of the spectrum who, you know, much as it's hard for people such as yourself, Keith, as an interventional cardiologist, you know, only sadly represent, well, not sadly for them, but only represent a comparatively small, you know, group of the total number of people affected with coronary disease. And I think, again, you know, this is where I think, you know, early treatment, and I think, you know, there is a great statement, I think, about Confucius about, you know, doctors who treat disease, you know, are beneficial. Doctors who prevent disease, you know, are truly beneficial, because actually we shouldn't be waiting for people to get symptoms of angina before we start taking their coronary disease seriously. And I think, you know, we are, and again, Dave Newby's work, and I think some of the work being done in Holland with the Rubinska trial, you know, are looking at, you know, the role of imaging in people, you know, much earlier in the sort of risk factor profiles. And I think, you know, the use of, you know, statins, which, you know, I think most people would accept are cheap, highly effective drugs, you know, not just for coronary disease, but more broadly as well with the pleiotropic effects. You know, I think, you know, this is where I think the realm is going, and it's actually trying to stop people getting into that ischemia cohort, if you like. And I think we have a real opportunity to be much more targeted, you know, in that area. So, you know, and I think from a health economic perspective, you know, and again, we await the health economic analysis to be published from ORFAN, which I know is submitted and is under review. But again, I think, you know, if we can stop people having events and being hospitalized, that will have a much greater effect on, you know, not just individual, but societal health and the cost of coronary disease, you know, to society as a whole. So yeah, no, absolutely, lots of things to consider.
Thank you, Dr. Nicol. You made a comment about possible health economic benefits, and we've got a question about that, so we'll come back to it in just a moment. But whilst we're on the topic of plaque specific, I mean, as an interventional cardiologist, it's still, of course, hugely beneficial that all those patients going through CT coronary angiography, the ones without obstructive disease, which is the overwhelming majority, they stand to benefit enormously from having their risk assessed and their disease more characterized using PHI score than only the patients who need to come to the cath lab. Dr. Antoniades, you showed us that really intriguing case of a patient who'd had an acute myocardial infarction and there was locally high inflammation around the culprit lesion. Do you think there's the future potential? Obviously, Carrie Hart already reports PHI score in each and every coronary artery. Do you think there is the future potential for local inflammation around culprit plaques to be detected?
Yes, absolutely. So at the moment, what we have in our hands, the validated PHI score, is measured the proximal segments of each one of the 3 coronary arteries, and it reflects the overall inflammatory burden of that particular artery, not a plaque-specific inflammation. However, it seems that we are able to pick up the individual plaques and quantify the degree of inflammation, hence the degree of possibly instability of these plaques. If that is proven to be indeed the case, then I see a future where we decide which plaque to be stented or on which plaque to intervene, independently on whether they are obstructive or not, on the basis that they are unstable or inflamed. And we have the recent clinical trial that shows that there might be benefit on that. If we can guide stents based on intravascular imaging, why can we not guide stent deployment on unstable plaques on the basis of inflammation? That's just something to think about in the future.
That's an intriguing future possibility. So we mentioned, Dr. Nicol mentioned possible health economic benefit. And in your presentation, you did show that you have some data that's in the Lancet publication on a sort of proof of concept real world evaluation from the National Health Service showing how treatments change. What are the likely health economic benefits of identifying high-risk patients through FISCOR using CariHeart and then getting them on maximal medical therapy? What would the long-term benefit be, and what are the health economic implications of that? Dr. Antoniades.
Yes, so we have a study that is already submitted, so we have the results. I don't think that we can discuss the details, the numbers behind those results. However, it seems that it's highly cost effective if we intervene on time, early in the disease process, and we treat these patients with standard of care driven by risk. If we increase the statin treatment, if we initiate statin treatment on top of other medications, or even if we add colchicine, then all these interventions reduce risk and they are cost effective, at least in a centralized health care system like the NHS in the UK. Additional studies will be needed, of course, in other healthcare systems, and particularly in the US, which is more fragmented.
Yeah. Dr. Neubauer, in the NHS study in the UK, do you want to comment on the sorts of changes in treatment that were observed in a real-world evaluation? I mean, when physicians were shown the result of the FISCOR analysis of patients undergoing CT coronary angiography, Dr. Antoniades demonstrated some data showing that there were some quite striking changes in treatment recommendations. That was in the UK. Do you want to comment more on that?
Yeah, so indeed, in 45% of the patients, a change in medication was recommended, and that could be starting new statin treatment, it could be increasing the dose of the statin, or it could be thinking about additional therapies such as ezetimibe, colchicine, which we've discussed at length. So I think that's a very striking finding that certainly we will also want to replicate in other populations in the future.
Yeah, and I think we've also had a comment, haven't we, about this may well be a very powerful technology in the evaluation of new therapies. So drugs that are undergoing clinical trials that are targeting inflammation, coronary inflammation. I think the concept of being able to identify patients who are at highest risk, and as Dr. Blankstein said, not only using CRP, which is a systemic biomarker, but a coronary specific marker of inflammation, and to recruit those patients into clinical trials of anti-inflammatory therapies, and to use the change in FISCOR as an early test of drug efficacy. That should accelerate the way that clinical trials are done in this space. Dr. Blankstein, do you want to come back and comment on that concept? So using FISCOR as a way of identifying patients and making clinical trials more powerful and also quicker, of course.
No, I think that's a very important concept because we have a lot of good potential drugs in the pipeline, but trials are very expensive. And I think a key for trials to identify patients who benefit the most from therapy, both because they have a higher risk or because they have the right biology that the therapy is targeting. So I think if you have a therapeutic that's targeting inflammation, it seems like a very promising biomarker to use it in the trial as a potential endpoint or for enriching the population that's being enrolled in that particular study.
Great, thank you. Well, we've covered a lot of ground. We've discussed a number of really important points, but I'm afraid our webinar time has now been used up. So I'd like to thank all of you for making time to participate in this excellent webinar. I'd like to thank Dr. Harris Antoniades for being our keynote speaker and for his excellent presentation, and to our panelists for contributing to such a lively discussion and for covering so many important points. Thank you to the SCCT and Caristo Diagnostics for sponsoring this webinar. And I wish you a good afternoon and rest of the day.